even if it's the post-lunch session, you'll get your sleep after an hour or so when you finish both the lectures, so you do not become drowsy till then. My talk is basically a crux of all that has been told to you in the last few lectures, and it will be mostly case-based, how you approach a case of malignant effusion and how you diagnose the case using basic stains as well as advanced studies. Now, ancillary studies encompasses processing methods to optimize the amount of diagnostic material or cell harvesting. Now we know Dr. Bhatt told us cells can be harvested, or you can increase the cellularity of a specimen using different techniques, and one of them is the liquid-based cytology. Have you all heard about it? It's a very upcoming technique, and basically it was started for cervical cytology or the pap smears. Now world over, pap smears are being done with the liquid-based cytology. But then this technique is being used also for fluids, also for FNA, sputum and all other samples. But you really need to have experience to interpret the cells when you use it for cells from other source other than cervical cytology. So I will first just deal with this technique because we have been doing it. It has started in our department also, and I have myself been doing it for the last 5 years. Now in this you are seeing a cervical brush. So the pictures are from cervical cytology, but if it is a fluid specimen, you have to add equal amount of fluid in a vial which already contains a weak fixative. And then once the vial is in your laboratory, the vial is vortexed or it is spinned so that the randomly joined material, it is separated out, the inflammatory cells, the mucoid material, these cells are separated from each other. If they are loosely adhered cells, they are also separated, but the true clusters, they still remain together, which you can see in the subsequent preparations. Now in the next picture you can see this is the this machine. This is the PrepMate, which is a part of the automated LBC machine, and that processor, it punctures the vial and removes, after vortexing, it removes around 8 ml of the fluid, and that 8 ml of the fluid is transferred to a density reagent. As you are seeing here, then you get RBC separately, you get WPCs, you get mucous material which is entangled. They all come in a different layer. Now you can see the stepwise preparation. In the figure 1 you can see the machine where you are putting all the tubes for centrifugation, and then it is gradually, then it is the density gradient material is, reagent is put, and you get the cell pellet. Again you decant the supernatant, again you centrifuge it, and again you decant, and what you get is a very nice clean cell pellet, which has now to be transferred automatically onto a glass slide. This is very important. This is the automated stage of the machine wherein at a go you can process 48 samples, and all that you are seeing here, these are the settling chambers. These are plastic chambers. They are fixed onto the glass slide. Beneath the settling chamber you have the negatively charged glass slides which are provided by the company themselves, and you can see and after that you have to do the staining. Now see, this is the homogenized cell pellet which you want to transfer, and then these cells, they are transferred. Now how do you get a mono layer of the cell? Now these glass slides, they are negatively charged, and as the cells start settling on the glass slide, the negative area is gradually occupied by the cells. So once the complete area is occupied by the cell, a second layer of cells cannot sit on the first layer of cell, and this is how automatically the cell transfer stops and you get a mono layer of the cell. So that's why in liquid base you get a nice single mono layer preparation, and this is just showing how the cells are transferring. And after that the stain is also automatically administered, and you the slides are stained and cover slipping is done, and they are ready for interpretation. Now as I told you, it's a big station, it's a costly machine but worth it, and you can process around 48 slides or 48 samples in one setting. Now if you have to do this process manually, you don't have the automated station, what you need is that plate, you need the negatively charged slides, and you need these settling chambers. And through this you have to go on putting manually the cell pellet, and that settles on the slide, and the whole process is manual. But then ultimately the preparation you get is similar to what you have done in the automated machine. Now a lot of companies have come up and they have started their semi-automated type of monolayer preparation. So this is the cassette, this is how the chamber is there, there is a slide over here and it spins, and they are coming up with different innovations, and you have the semi-automated, like the UPrep company is marketing that a lot, and any and every medical college or even a private setup can afford to have that type of preparation. Now the second preparation is the thin prep procedure for making liquid based smears. Now what is done in this, again there is dispersion of the cells by spinning the cells. Here you have a vial and you have a cylinder too. At the base of the cylinder you have a filter membrane. So it is a membrane based technology. Now after the vial or the material is spinned and the loose clusters are separated, there is a vacuum is applied to this, and the cells, they start depositing on the membrane. Now again, why you get a monolayer is because each of the pore of the membrane is occupied by one cell, and after all the pores are occupied, automatically the suction process is stopped by the machine. Now this filter is then inverted, and now the process to transfer the slide cells from the filter onto the surface of the slide. Again, these slides are negatively charged, and the properties of the slide and the cell adhesion properties of the cell themselves prefer getting transferred onto the negatively charged slide. And a slight air pressure is applied, and all the cells, they get deposited onto the slide. And these are again stained automatically. You have a single slide processor, which is also known as T2000, or you have a big station which processes around 80 samples together. So that's used for cervical cytology. Now you can see these two preparations. With the thin prep you get a diameter of 20 millimeter. With the sure pack you get a diameter of 13 millimeters, and the cells are there in a monolayer. The advantages are very obvious. It's a very nice cell enrichment technique. There is a uniform distribution of cells, and the morphology is excellent. And you have a very clean background, and in that clean background you can see the nuclear details and cytoplasmic details very nicely. But one of the most important advantage of LBC is that some amount of material is always left back in the vial, and then you can use that material either to prepare more slides for your, if you find some few cells in the first slide, you can make one more preparation, which is otherwise not possible when you are doing the conventional smears. So you have residual material remaining, you can use that material for preparation of cell blocks or any other molecular techniques, and that's why a lot of molecular techniques and immunocytochemistry is being done on liquid based preparations. Now what is the limitation of LBC? It's impossible to assess the adequacy of the material. You are taking a sample, suppose you take FNA or you take a sputum sample or you take a fluid sample, immediately you have to put it in the vial. So there is no scope of doing on-site evaluation of the material, which is, you must have heard about ROSE, that is the rapid on-site evaluation of the material. Once you have this facility of ROSE, then you know what is the composition of cells in that sample. If you see caseous material, you will make an extra slide for AFB staining. If you see hematolymphoid cells, you will immediately put some amount of material in the flow cytometry tube. But this facility is lost because whatever material you are getting, you have to immediately put in the vial. Apart from this only disadvantage, rest all it is a very nice technique for interpretation of the cells. Now coming to ancillary testing, we have a host of tests which I have enlisted over here, and we can use all these special techniques for a basic for two basic clinical scenarios, where you want to first identify the malignant cells in a effusion and further qualify them, and second, when you want to differentiate a mesothelioma from a metastatic adenocarcinoma. These are the basic two clinical scenarios where you require so many techniques. Now when are these studies needed? Other indications, as I told you, the basic to resolve the gray areas in fluid cytology, the mesothelial trap, where you want to differentiate reactive mesothelial cells from adenocarcinoma cells, or reactive mesothelial cells from mesothelioma cells. Or when you are not aware of any primary, that is an unknown primary and the patient comes to you with only massive pleural effusion or massive ascites. Or when you want to do subtyping of malignant small round cell tumors, and also when you want to subtype the hematolymphoid neoplasms. The other areas when it is helpful is prognostication. When you are giving a specimen as positive for malignant cells, you are conveying to the clinician that the stage of the disease is higher, and likewise the patient has to be treated. And also sometimes you are required to provide evidence for expensive targeted therapy. If in a lung carcinoma you are able to type it on fluid cytology using cell blocks as small cell carcinoma, then there is definitely a hell of difference in management of the patient, because they get that exact targeted therapy. Now, what are the prerequisites of ancillary technique? Making available all clinical and radiological details. You should know everything about the patient before you are applying a technique which is higher than your routine preparations, like the routine HME papinocolor stains. You should make all the clinical details available. Have a good quantity and quality sample. Quantity definitely depends on the clinicians. They have to send that sample to us. And many a time they retain a lot of sample and they just send a small penicillin bottle of 5 ml, and there 1000 ml fluid will be remaining in the ward. No, you have to assure that you get maximum material so that you can also prepare cell blocks from that sediment. Quality, these two points are the responsibilities on the laboratory and the clinician. It's a joint responsibility. The quality of sample, it is our responsibility. Once it comes to the lab, we have to be really pretty fast to process it and not keep it there on the rack lying down for say a day or two, and then you think of processing it. So you have to process it pretty fast. And you should have a very good tentative diagnosis on morphology. Make conventional smears, do all your routine stains, keep a holistic approach. If you have some special stains, add those stains, and you frame a diagnosis very near to a final diagnosis. Only when you have to add a particular advanced technique, you have to just, so that it is once level up, it helps you to give you a final diagnosis. So your basic morphologic diagnosis should be almost ready with all the radiological and clinical details and whatever material you have with you. And all these efforts are to identify the second foreign population of cells, which Dr. Pangarkar has also told us in the beginning. We'll see what is that. Now this is just a small algorithm for evaluation of this second population of cells. We know that the native population is the mesothelial cell, and anything which is coming there as metastasis is a foreign population to the effusions. Now cells in the fluid, they are either mesothelial cells or they may be non-mesothelial. Mesothelial cells, they can be reactive, and just to recap, they are single cells without large three-dimensional groups, or they are neoplastic. And as she said, the quantity and quality of these cells has to be looked. There will be too many cells, and there will be very large groups. There will be multiple cells with binucleation, multinucleation, and all features of malignancy, and in that case you can call it a mesothelioma. Or you can have non-mesothelial cells as hematopoietic cells. They are again non-cohesive cells. They could be reactive or they could be neoplastic, and then you can label it as lymphoma and do the further workup. And if it is again a neoplastic population, but it is a second foreign population that we are interested in, you can call it a carcinoma. They come in cohesive groups. Sarcoma, they come in spindle cells, and you can have melanoma again, which comes in non-cohesive groups. Sometimes the second population of cells is so high that you do not get any reactive mesothelial cells. So in that case, you really cannot apply the concept of second population cell. It is one cell type, and you have to identify whether it is a metastatic or it is a primary. Now it's very easy to make such a nice flow chart and tell everything. Everything does not turn up the way it has been projected. It's a really difficult exercise, and I will be dealing with all the difficult cases, how we resolve them with the help of special stains and immunocytochemistry. And especially we will be dealing with cells which defeat the standard teaching which you have been listening to up till now. Now just coming to case, the first case. Now this is a 52-year-old female presented with shortness of breath, increasing abdominal distension for 3 months. She is a known case, operated for a complex right pelvic mass 1 year back, and she has come again with massive ascites. And paracentesis was done in this patient. 1500 ml thick mucoid fluid was removed. Can you think of something? She's a female. What do you expect it is? It's an ovarian carcinoma. The first thing that comes to our mind is ovarian. Then we have said thick mucoid fluid. Mucinous cystadenocarcinoma is the first possibility. So here you get this abundant mucin, cells floating in that. You can see the papillary clusters. This is the MGG stain where you can see that pink or metachromatic mucin in the background. And this is the papillocorostone stain where you see it as the grey-green mucinous material. And this was the histopath of the slides of the patient which were sent to us for review. Now this is a clear-cut case. Here you need not do any special stains or any special techniques. And what would you sign it as? Positive for malignant cells, consistent with metastatic cancer from the previous neoplasm. Everything is known in this patient and it is positive for malignancy. Now in another scenario, this is 56-year female, history of tobacco chewing 40 years. CT showed a mass in the lower lobe of the right lung and pleural fluid was sent for cytology. Now here you can see the smear showing these clusters of cells. As you increase the magnification and see other fields, you see that these are present in acinar or tubular groups. Here you can see small acinar pattern. You can see these clusters, there is peripheral vacuolation, and you can see some intranuclear inclusions. And this appears to be a straightforward adenocarcinoma. So it's a very clear case of adenocarcinoma. Now you have a CT mass in the lung, and it's a peripheral mass. The chances are that it correlates with the cytological finding that it is an adenocarcinoma. But in case, so you report it as consistent with primary site. But in case you have a doubt that this mass which you are seeing on the CT is metastatic from some other site, you need to do a marker. And the most appropriate marker to confirm the primary, thinking that this is primary of the lung, is the TTF1, that is thyroid transcription factor 1. Of course, P63 can be utilized when you have a doubt of even squamous cell carcinoma in another scenario. So just a single marker of TTF1 on a cell block will tell you that this is an adenocarcinoma arising from the lung. So here you have resolved this issue. Now another scenario, you have a 50-year-old male, history of heavy alcohol abuse, and just there is a history of distended tender abdomen. Now you do not have any radiological findings, you do not have any more clinical details. How are the cells present here? They are in the form of, they are dispersed singly, most of these cells, but there is a variety of cells in this specimen. Here you are seeing some lymphocytes-like cells, here you are seeing some reactive mesothelial type of cells, and that too they are looking little atypical with large enlarged nucleus, some clustering here and there. You are seeing some distended cells, or would you like to call them signet ring type of cells. So you don't know what exactly, what is the source of these cells and whether or not this is a mesothelioma or it is these are the metastatic cells or the second population of cells. Now before embarking on very costly immunocytochemistry and making cell blocks, you do have some histochemical stains which are very, very helpful, and these include mucicarmine, PA stain, Alcian blue, and if used judiciously and with full understanding, you can really get some help. And these are the stains that are available very handy in every pathology department. They are being done in the histopathology department. You can utilize them similarly in the cyto section. Now, mucicarmine, it is negative for mesothelial cells or mesothelioma, but it's positive. It's a very specific stain. It is not very sensitive. All these histochemical stains, they have their own limitations, but they are helpful if used consistently, persistently, and very judiciously. Now, once mucicarmine is positive, it tells you two things: that for sure you are dealing with a second population of cells or an adenocarcinoma, and surely these cells are not mesothelial cells. It is that specific. You have another stain which is the PA stain. This is highly sensitive. It will stain any glycolipid, glycoprotein, anything it can stain. and it is positive in both the mesothelial and the adenocarcinoma cells. But if it is used along with diastase digestion, it provides more information. But in that case, you should have a training to interpret the cells after diastase digestion. The past positive material disappears after you treat the slides. You treat the slides with diastase and stain them with past after that, but it remains positive in adenocarcinoma cells. For this, you need to mark the area where you are interpreting the positivity. Another stain is the Alcian blue stain. Now we all know that mesothelioma secretes mesenchymal mucin, which is acidic. All these three we are dealing with are neutral mucin, and Alcian blue stains mesenchymal mucin, and again it is positive. It is very sensitive, positive both in mesothelial cells and adenocarcinoma cells. But if you treat the slides with hyaluronidase enzyme and you restain it with the Alcian blue, it is digested in mesothelioma and it remains positive in adenocarcinoma. So you have to utilize these stains as according to the availability in your department. Now in this patient, the one we were talking about, we did a past stain and it remained positive after diastase digestion, telling you that you are dealing with neutral mucins. Now, as I told you, past is positive even in the mesothelial cells. But the positivity, the quality of the positivity is very different. It is very dense, thick, and it is in the form of a polar arrangement. Here you can see at one end of the cell you get dense, thick positivity, as against this granular positivity or a targetoid type of positivity which you get in when you do stains for neutral mucin. Now in this, what would you report it as? We got the feedback from the clinician that the patient has a thickening of the large and small bowel wall. And what did we give? Metastatic adenocarcinoma, possibly. The primary site is in the upper GIT, and all this thickening of the small and the large bowel is metastasis, and even there are metastases in the abdomen leading to peritoneal effusion. So with the help of these special stains, we can still suggest the primary site. And another scenario, female 53 years, massive ascites. What you are seeing? Very nice clusters, malignant cells, papillary groups. When you see these clusters in higher power, you can see acinar arrangement of the cells within the cluster, which is a classical feature of metastatic tumor or adenocarcinoma as against mesothelioma. And you are seeing a very smooth community border that indicates again a epithelial malignancy as against the mesothelial malignancy. Here you are seeing some calcified material. I am not sure whether samoma bodies should look like this. They are very smooth, round, but there is some calcified material, and again you get these clusters of malignant looking cells. Now do not rely too much on samoma bodies, because they can be seen even in reactive papillary hyperplasia of the mesothelium. They can also be seen in primary peritoneal carcinoma, which is carnitine negative. And you can get all these features, confusing features, so do not rely too much on the samoma bodies. So we went ahead with the preparation of cell blocks. This case was contributed by Dr. Bharat Rekhi from Tata Institute. And in the block also we could not resolve the dilemma whether it is an adenocarcinoma or it is a mesothelioma. So what do you do next? But basically you had the feeling that this is an adenocarcinoma, so you apply this marker, BER-EP4 positive. Now these are markers that stain glycoproteins which are present on the cell surface, cytoplasmic membrane, and also within the cytoplasm. So you get a membranous positivity, and you know that we are dealing with epithelial cells and not mesothelial cells. And the second marker, because she is a female, and you have already suspected that this could be a serous papillary carcinoma, you apply CA125 and it comes heavily positive. Now what is more important, that you observe the membrane positivity over here. Here you are seeing cytoplasmic positivity. So with each marker, the nature of observing the nature of positivity, the location of the positivity is also very important, and with these findings you can pinpoint label it as serous carcinoma of the ovary. In another scenario, this is a female 27 years. This is what was written on the requisition form: simple ovarian cyst, query carcinoma. Now a 27-year-old female, query carcinoma, I mean, you can get ovarian cancers in young age, but it's slightly difficult to digest. Another thing that was written was exploratory laparotomy done, peritoneal fluid sent for cytology. Now we are not sure whether this peritoneal fluid is a minimal ascites that was there and that ascitic fluid was collected, or whether it is the washings they have done. So I think this is a universal scenario. We all receive such requisition forms and we have to go and find out more details, tell our residents to run around for history and other details. Now with this history we got this type of cytology. Here you are seeing honeycomb cells, regular distribution, slightly folded margins of these cell clusters. As Dr. Pangarkar told us that peritoneal washings, they yield abundant cellularity and you can get two-dimensional clusters, but within the cluster there is a very regular arrangement and there is hardly any atypia. So we were confused whether we are dealing with peritoneal washing fluid cytology or we are dealing with ascitic fluid that was present there. Now whenever you are collecting such a intraoperative specimen, the first thing you have to do after opening the abdomen, that is what the books mention, is take the sample. Do not even remove the tumor because there could be spillage of malignant cells in the peritoneal cavity. Some more areas show these types of cells, again two-dimensional cells. Here you are getting a string of mesothelial cells as if it has been forcibly removed from the mesothelial lining, and these two-dimensional clusters, but there were some small clusters which were looking very atypical, higher magnification of this, and then you start doubting whether you are dealing with a second population of cells. In the MGG stain, naturally the cells look a little bigger and they had more adenocarcinoma-like appearance, and you could see some mucin over here. So we were confused whether this is an ascitic fluid or not. So the most handy thing, as I told you, we have PAS with us. We did diastase. We applied diastase to the slide and then did a PAS stain. Still we got positivities telling us that this is neutral mucin. But with the Alcian blue, we do not have the hyaluronidase enzyme, so we could not confirm that. Now in such a case, the suggested immunochemistry markers. This is a little bit of theoretical thing, but you need to understand this for applying it in future in your practice. The thing we wanted to differentiate here is whether these cells are reactive mesothelial cells or they are adenocarcinomas. Now we know carbapenem, CK5-6, they are all non-specific stains. They can be positive in both the scenarios. Desmin, as Dr. Pangarkar said, it's positive in the reactive mesothelial cells and it is negative in the adenocarcinoma cells. And then you have a host of these epithelial markers, EMA, MOC31, BR, EP2 and B72.3, which help to tell you that this is adenocarcinoma. Now, the first thing that you would do in this case is confirm whether the cells in question are mesothelial cells or not. So, we apply the calcretinine. It is a neuron-specific calcium-binding protein. Neural tissues and few other cell types like mesothelial cells take a positive stain. You do a cytokeratin 5-6. These are all positive. Even HBME, WT1, mesothelin and a new marker podoplanine. These are all positive for mesothelial cells. At the same time, they may show cross-reactivity even with the epithelial cells. Now here you can see these reactive mesothelial cells. But the advantage of applying the mesothelial cell markers is that first thing, they highlight the reactive mesothelial cells, and second, the negatively stained second population of cells is also highlighted. So in that case, if you have a reliable marker which will be consistently negative for the mesothelial cells, that could be a indirectly positive marker for the mesothelial cells. So you have all these markers, the adenocarcinoma markers. They are also called as negative mesothelial markers because they consistently do not stain the mesothelial cells, and that is how they indirectly help you to identify the second population of cells. And this we subsequently got details. The patient, the CA125 was very high, and we received a mass which was 28 by 22 by 18 centimeters, and this was a borderline papillary serous tumor. And around 15% of the borderline tumors, they can give rise to ascites, and around 30 to 50% of patients with borderline tumors and having peritoneal implants can have ascites. So always be aware of that. Now this is another scenario where you have a female 60 years, only history is pleural fluid for cytology. Here you are seeing lot of cells, you have cells distributed singly as well as in small clusters. As you look at these cells in higher magnification, this is a proliferation sphere. Now this could be a sphere coming either from mesothelial cells, look at the quality of these cells, and I feel that there are some windows inside, and these could be mesothelial cells, but there were cells which had more papilloid or a group of cells or a morular type of appearance where you can call them cells coming from adenocarcinoma. Now what will be your differential diagnosis? Primary adenocarcinoma, because it is a pleural fluid, it might be coming from the lungs. It could be a metastatic adenocarcinoma from some other organs of the body to the lungs creating pleural effusion, or it could be the epithelioid variant of mesothelioma. What do we do? Now in this case, again, first thing, you will apply markers which will differentiate your doubt regarding reactive mesothelial cells from the malignant mesothelioma. But we received history that this patient had bilateral breast masses. Now what do we do? Still the doubt of those reactive mesothelial cells which were appearing like mesothelioma cells is there in your mind. Although you have got a history of bilateral breast masses, it could be an adenocarcinoma. This doubt is there, so you apply the markers for mesothelial cells as well as you apply the markers for the adenocarcinoma cells. Now you have a 29-year-old female. Till now we were dealing with all the epithelial tumors. This is a different case. You have a young female with a history of shortness of breath of 3 weeks duration, cough, right-sided pleuritic chest pain, and pleural fluid was sent for cytology. Her imaging features reported that there is a possibility of lung metastasis over infective etiology, and this is what we saw. Abundant cellularity, and because the patient was breathless, each time they were doing the paracentesis, and each time we were receiving the fluid, and each time we were getting this type of abundant cellularity and typical morphology. You were getting these cell balls or cannon balls or morulas, what would you like to call it. And again, see these cannon balls when they are dividing so rapidly and they are creating babies, and when the babies have not been separated, they start looking like papillae. So it's a very difficult situation, but when we looked into these cells under higher magnification, they all appeared spindle in appearance, and there were very few cells that were looking epithelial-like. So here you can see a bit small balls, baby balls, but all of them were composed of spindle cells. There was also a doubt whether these are epithelioid granulomas, because that's the commonest condition in our country. So our cytologic impression was spindle and epithelioid tumor, query primary, query metastatic. Now if you are convinced that this is a spindle cell tumor, it could be a mesothelioma, monophasic or the fibroblastic variant, it could be a fibrosarcoma, it could be a smooth muscle tumor of the pleura, anything, and of course tuberculosis was still lingering in our mind. But there was a missing link. We got more reports, we were insisting the patient to get more details, and we came to know that she had undergone hysterectomy and she was had been reported, leiomyomas were removed, and she had a report of leiomyoma. Now with this report of benign leiomyoma, again what should we label this fluid as, because the cells were looking very bland. So we kept it as benign metastasizing leiomyoma, you know this condition. It could also be a very well differentiated leiomyosarcoma coming either from the uterus, or it could have been coming from lung or pleura if that was really a benign leiomyoma. So we asked for the review of slides and more sections from the uterine leiomyoma, and also asked the chest physicians to do a biopsy from the pleural nodule. The biopsy was done, but it was very tiny. It also showed those similar spindle looking cells, and it was not enough to conduct an immunocytochemistry. So what I did, we have a very good team of cytotechnicians, and they do all permutations, combinations. So we destained one of the H&E slide and we stained it with a Masson stripe home stain. And you know the muscle cells, they stain red. Each of the cell took a red positivity in the cytoplasm. This stain told me that these cells are belonging to the smooth muscle family. So they could have come from the leiomyoma of the uterus or query well differentiated leiomyosarcoma. So I really got good help from this stain. And we did receive that single section of leiomyoma from that patient, and we critically looked at these slides, and there were small areas of necrosis, and we really thought that this was a very well differentiated leiomyosarcoma that has been metastasizing to the lungs and the pleura. And this is another scenario where the patient has massive ascites, 53-year-old with bulky ovaries. Now this history is little confusing, and the patient has malignant, labeled as malignant effusion. This case was contributed by Dr. Sanjay Navani, who does a lot of immunocytochemistry for whole of Maharashtra. Now what is the cell type? Here you are seeing, again you are seeing two population of cells, but all in all these cells, they seem to be belonging to a family of mesothelial cells. Here you have some reactive mesothelial cells, some are looking like malignant mesothelial cells with binucleation, multinucleation, prominent nucleoli. But then with this history of bulky ovaries, the point that it could be a second population of or a metastatic population does not go out of your mind. He prepared a cell block out of this specimen, and here you can see again a lot of malignant cells cannot be further qualified, but they are looking like epithelioid mesothelioma, and immunochemistry was done. Carl-retinine CK5-6 was done. Now these two stains, we know that they are not very specific, but if you, for mesothelial cells or mesothelioma, but if you add the stain of podoplanine, now podoplanine is a new marker coming up, and it was basically found in the lining cells of the lymphatics. And then gradually it was investigated, and it has been found to be a very specific marker for the mesothelial cells, but it is also positive with the reactive cells, benign cells, as well as the malignant mesothelial cells. So, but in addition to these two markers, a more specific marker as podoplanine does tell you that we are dealing with a mesothelioma case. What are the limitations of immunocytochemistry on cell block? First thing, there are a lot of technical limitations, there are interpretation errors, you may be a novice, you may not able to interpret the nitty-gritty and details of the ICC block, there are too many of them. But how can you overcome the pitfalls of immunocytochemistry using the cell block? Look at the positivity and judge which cell are you interpreting. Are you looking at the positivity in the cells of interest, or you are getting lost in other cells which are non-specifically being stained with the carl-retinine or CK5 and 6? Whether the positivity is strong or weak. When we read all journals for this type of cases, you see that the positivity is reported in terms of 1+, 2+, 3+, weak, moderate, strong. So that is a matter of practice. You have to really practice which is weak, which is moderate, which is strong positivity. So that has to be really mastered. And third, most important is you look at the location of the positivity. Where are you looking it for? Whether it is in the nucleus, whether it is in the cytoplasm, whether you have applied proper controls for the similar setting to say that yes, I have got membranous positivity or not. So in order to locate the positivity properly, you have to, in a cell block, you have to orient the serial sections identically on the slides, and this approach is known as the subtractive coordinate immunoreactivity pattern, or the SCIP approach, which has been described by Dr. Vinod Siddham in one of his books, and he was also our teacher with very good experience in cytopathology. Now he says that you have to have the sequence of the, when you are cutting a cell block, you need to place the sections very serially and one after the other, so that you can locate the same group or same cluster of the cell on the slide and go on applying one marker after the other and do interpret in a mathematical manner. But provided you have the same group on which all the markers have been applied. And this needs lots of efforts, because once your slide is exhausted and you are taking the section on a newer slide, again you have to keep track of that particular section. So it is the serial section and identification of the serial section which is very important. Now if you are suspecting a hematolymphoma malignancy in your effusion, you have two options. You either do a IHC on a cell block or you do a flow cytometry. Most of the institutes are having this facilities these days. If it is a reactive population, a lymphoid cell population, and they are generally T cells, they will show polyclonality. If it's a low-grade lymphoma, it can be diagnosed as B cells with the restriction of light chains. Rare large cells in effusion, and if they are identified as lymphoid cells, they need to be differentiated from other epithelial malignancies. And on the cell block, the markers, you have the panel of markers, and that can be decided based on your suspicion. Electron microscopy, Dr. Pangarkar has told us, it has a limited value, but it's very tedious, costly affair, not used in your day-to-day life. Of course, cytogenetics and using the fish and the CISH technique is very helpful in translocation of the chromosomes. Now again, I will repeat, outright positive metastatic adenocarcinoma with a very nice clinical and radiological details, it's not a problem. But when you do not have, either you do not have clinical details or you have an equivocal effusion cytology, this is the way you have to go about it. If you have enough material and you can make a cell block, it's well and good. If you do not have enough material and you cannot make a cell block, ask them to send more fluid which must be lying in the ward. Or if they are doing a paracentesis, again tell them to send you more fluid so that you get enough sediment for a cell block. If you have a cell block, you do immunocytochemistry. If you do not, ultimately you cannot prepare a cell block, you just report it as suspicious for malignancy, submit more material. If you have ICC and you are suspecting that there is a single population of cells, they are all native cells, or it depends if you are suspecting a second population. With the first scenario, you have to look at the quality and the quantity of cells, which is more in mesothelioma, and then the markers that you will apply will be WT1, EMA, HBME positive, and all the negative markers that I was stressing on, which are adenocarcinoma markers, can be applied and the dilemma can be resolved. With the second population of cells, the basic panel you apply is cytokeratin, which is generally positive in all epithelial malignancies, and you do a vimentin, which is a common stain for all soft tissue lesions or spindle cell lesions. And if it is cytokeratin is negative, you suspect a lymphoma or a sarcoma. And if cytokeratin is positive, vimentin is negative, you suspect a carcinoma. And then depending on the immunoreaction for negative mesothelial markers, you proceed with immunopanel for primary or restricted panel to confirm a known primary. Thank you so much.
Thank you very much, ma'am, for taking us through the various ancillary techniques in fluid cytology.